This is exciting. I'm excited to be here. Thank you all. We want to thank the California Healthcare Foundation for putting this together, being really supportive and allowing us to have these deep conversations about racial bias and healthcare. I'm Ivelyse Andino. I'm the founder and CEO of Radical Health. And what we do at Radical Health is look at health equity through meaningful conversations and tech. So we had the opportunity to build an app which uses AI, and what we're doing with that is helping folks, especially pregnant women of color, know their rights as it pertains to the healthcare system. So we're giving them questions to ask before an appointment, during an appointment, questions like you can ask for a translator or ask for a second opinion. And it's really exciting to get to do that work on the ground. We combine that with in-person workshops and trainings, but to really see at the forefront how important equitable care for everyone is. And so what we want to do is get everyone, we have an incredible panel today, and we'll have everyone introduce themselves. The rule is that we have to say a fun fact about ourselves. So we'll say, where we came in from and what our fun fact is. So I came in today from the Bronx. My fun fact, which is a little related, is that I am the trap queen, trap karaoke queen. So as I'm writing about health equity and all this fun stuff, I love to listen to really horrible, ratchet music.
Good morning, everyone. I am Melissa Jones with Bar High. We're the coalition of the Bay Area's 9 public health departments. And they founded us to focus exclusively on the issues that are impacting health in addition to healthcare, the way that all wellness wraps around each other. I'll talk about it more later. I came in from Oakland, and it's so nice to hear so many people on the panel. Got to spend some time in Oakland, and just it reminds me how fabulous it is, which I always know. And I guess my fun fact would be that I was the shot blocker in high school, and so I'm kind of a quiet person, but people are surprised to see me quite on the court. Yeah.
Great. Good morning, everyone. I'm Rubina Ohanian. I'm with Accenture, and I lead our Southeast Data Science and Responsible Artificial Intelligence. Great sessions. I was here yesterday, and really just every one of the sessions were great. Fun fact, I'm not related to the Kardashians. I am Armenian, though. My fun fact is I have 3 children. They all have the same birthday.
Oh, wow.
Wow.
And they're not triplets.
Great timing.
Good morning, all. I'm Gary Butts. I am the Chief Diversity and Inclusion Officer for the Mount Sinai Health System and the Dean for Diversity for our Icahn School of Medicine at Mount Sinai. I oversee all aspects of diversity and inclusion and regarding programming policy and ensuring integration across our system. And more recently, we are positioned to launch what is novel for a healthcare system and maybe the first in this space, a diversity innovation hub. More to talk about a little later. My fun fact, first of all, I'm from New York, out of Brooklyn. And the thing that I insist that all medical students learn about me before they graduate is that I'm a Yankee fan from Brooklyn.
Yeah, it's like a New York joke. So this is, this panel, we're going to talk about racial bias in healthcare. And so just a spoiler alert, we're going to talk about racism and really, get in there. That being said, right, this can be an uncomfortable conversation. The panelists are well equipped. We really want to make sure that as we talk about this, we're going to talk about race, we're going to talk about racism. And it's important to note that when we focus on a specific population or populations that have been underrepresented, that we do so with intent, and that when we focus on that, we all benefit. So the best example that I can give you as we have these conversations to kind of keep in mind are the curb cutouts or the sidewalk ramps. In the 60s, the ADA instituted like a law that required those sidewalk ramps when you go to cross the street. And that was really, again, for folks with disabilities, making sure that everything was accessible. But if ever you've sprained an ankle, if you ever had a toddler that was riding a bicycle or been on rollerblades, you know that's like you've benefited from those curbs. So as we talk about health and equity and racism and bias in healthcare, we're going to talk about people of color, Black and brown folks, immigrants, LGBTQI, so on and so forth. But keep in mind that when we talk about that, right, the tide rises, we all rise with the tide. And so it's important as we get into this conversation that we know that racial bias is both super personal and structural. And on this panel, right, we have an entire panel right now that has both lived that and works in that space. So I'd love to just go down and hear a little bit from you all about your experiences. So how have you experienced racism and health, both personally and structurally? So we'll start here and just make our way down.
Yeah. So Bar-High focuses on differences in life expectancy and on birth outcomes and then health equity in general in the Bay Area. And so what we know in the Bay, and it's really, I think, until people really look at the data and think about what it means, the heartbreak is not clear. But for people of color who are living in the lowest income neighborhoods in the Bay Area, when you compare their life expectancy to people who are living in the whitest and most affluent communities in the Bay Area, you see, depending on the county of the Bay Area, somewhere between a decade and 17-year difference in life expectancy. That difference is the difference of knowing grandchildren. And it's a difference that is marked by poverty and by race together. And there are a set of things we know about the neighborhoods where people live where that is true. And so we know that there are quite a lot of differences in terms of access to food, in terms of access to transportation, to job centers, to a range of things that create the fullness of our wellness. And so that, I think, is a issue that we face and talk about a lot that's really important to our work. And then it becomes very personal, I think, when you start to talk about people having their first child. And so for Black women across the Bay Area and actually across this country, differences in birth outcomes are very clear by race. And people have often wondered, is there something individually that women are doing that makes that difference happen? And actually, no, in fact. What we know is that the stressors of racism have a huge impact on health, and they have an impact then that comes out through the birth of children. And that's really become much clearer over the course of the last 4 years when there's been an uptick in rhetoric against particularly Latina people. And because what we've started to see is that the birth outcomes have started to edge towards what we've seen in African American women who have faced a lot of prejudice. And so we've seen the beginning reports of that coming out in multiple parts of our country now. And so that is a way that we've really seen a lot of the racism in play.
Thank you.
Yeah.
And Rubina?
You know, we don't see, at Accenture with clients, we don't see bias for lots of reasons, because the client doesn't tell us we have a bias issue, so you need to come and help us. But most likely they don't even know if they have bias in their data or if they have bias in their analysis. So, but from all the research that we're seeing, it is definitely a complex national issue we're facing. And just to give you simple stats, US was ranked number 46 for maternal mortality rates. Now, this is behind Saudi Arabia, this is behind Kazakhstan. So when we look at it from that perspective, and then we drill down at a data level, we see that there's an intersection of sexism and racism that is driving that.
Right.
So we're seeing, as we analyze the data, we see some of that emerge, some of the bias.
Sweet. And then personally, is there anything?
Personally, I'm a first-generation immigrant, and absolutely, English was my fifth language, so definitely saw a lot of bias. And my cousin, actually, who had a baby, I saw that at the hospital environment. So I've seen that, and which is what has attracted me to the area and to the topic.
Yeah. Thank you.
Thanks.
When I think about race and racism, it reminds me of
They're going to remind me to tell you to speak up a little more. Yeah.
Sure. When I think about race and now racism, it reminds me of how far we've come and how far we still need to go. Some 20 years ago, when I first came into the D&I space in our medical school, you could not mention the term race without looking over your shoulders. I think so. We've come a long way, and we can actually have a somewhat intelligent conversation around racism, and so that I think is a good to do. But it's a tough conversation. And just like gender, color of your skin is not something that it's an attribute that you can't run from. And unfortunately, the biases associated with gender and race play out in all kinds of interesting ways, and unfortunately get in the way of options and opportunity for folk all over the place, but particularly in particular for that group that I focus on, healthcare professionals. And so the fact that we struggle with the representation of people of color in the health professions is a stark reminder that we still have a way to go. And the structural play out of racism is alive every day. On a personal note, it reminds me that all the discouraging conversations I've had, and that I think the good news is that at least somebody was brave enough to have the conversation. It's worse how folk may have been talking about me without me present that have gotten in the way and what I've had to overcome to get to where I am today. It's a reminder of the work that still we have to do on behalf of the young people who represent our pipeline to the health professions.
That's a great point, because I think that is a topic that is not addressed. If you go through the literature, through the studies, racism and healthcare are not frequent. It's acknowledged that, yes, we have a racism issue, we have a sexism issue, but the studies do not dive very deep into those areas.
Right, right. And I think that this is all really important, right? So what we have, with Melissa on the ground, we're seeing huge differences in life expectancy, right? So the difference between seeing a grandkid and not, and like really experiencing that, maybe not even having the words to. So I'll say, again, from myself and the work that we do in the community, my community isn't walking around saying, hey, we have health disparities, right? They're living it, they're dying from it. Rubina, you're talking about in tech, right, where there are, almost echo chambers, but even like this unawareness of what bias is, but then still perpetuating the experiences that we see on the ground. And then for you, Gary, right, as you're bringing in new med students and really trying to undo some of this, but existing almost in the middle of like trying to create, new changes while also existing within the healthcare system itself. I would love to kind of go through that and talk a little bit more, and we'll go the reverse way. But for you, Gary, as you're creating this next generation of diverse students that are both have lived experience, coming from the community, know what it is, almost like your experience, what are some of the challenges you're seeing there in that space?
Yeah, I think the not having role models and mentors that look like them, that give them to acknowledge them and their experiences and challenges, that's number one. Number two, that they can relate to and see themselves as being successful professionals over the course of time. That's big stuff. Mindset, and I, as you can imagine, being, the only one of few black males on our faculty, and the only black male full professor in our system. I do a lot of mentoring, not just to guys, but I think, it's a challenge, and it's a particular challenge, and it reminds me, in a personal way, of what people call the minority tax. And so, there's probably a gender tax as well, and while that's important for us to realize, it's even more important to step beyond that and do what we have to do. The biggest challenge I have with mentoring students is to have them appreciate that they do belong here. They are welcome, they have value. In fact, they have particular value that is probably bigger and more particular than others who don't look like them. And once we can get there, then focusing on the typical things that are at hand to be successful in medical school. But that is an issue that plays out in all kinds of ways that gets in the way of success as a medical student, as a resident, and frankly, even as a faculty person.
And can you even, so what we're hearing and the audience wants to know, right? Like, and this is, shame on me, but like examples of bias, because we use this word too, right? And so as we go down, let's incorporate that. Like, what are the concrete examples that you've seen in this role as we look at some of the challenges?
I think, Yeah. We often like to aggregate socioeconomic status and race. And while sometimes it's hard because there's they often go hand in hand, but race in and of itself, just like gender, is right in your face.
Right.
And so all the things that can potentially get in the way that relate to differences play out in all kinds of interesting ways, including profiling, and that, unfortunately, particularly in New York City, it doesn't go away just because a student or a faculty member is on our campus.
Right.
These are things that clearly play out, oftentimes unintentionally, but still they play out. So that is
Some of that like implicit bias
that
there.
is one. And then I think that clearly the life of a person of color, even in the professions, is often not very different as it relates to challenges and overcoming and sidestepping the typical balances on a daily basis. They play out. I can remember, we all remember the Danny Glover story. Well, yes, I too on Fifth Avenue, have been passed by taxi cabs and
totally.
so on.
And so I think that talks to, right, like some of the implicit bias that's there, the profiling. And so that brings us, I think, right into you, Rubina, as we're talking about tech, the AI, and the work that you're doing. And so you mentioned earlier that there wasn't, folks didn't even recognize they have a bias. But so what are some of the challenges that you're seeing in your space and in your role?
So I think, just to clarify, not all the clients are in that mode, right? There are some clients who are very aggressively pursuing responsible AI, and you have that extreme, and then you have the other extreme that has been developing AI models for years, and they have a hard time managing the models, much less measuring whether they're biased or not. I think it's such a new topic. It reminds me of the 90s when the World Wide Web began. We had no idea what the impact would be in our life. And I think AI is very similar. We don't know what impact it will have. But you have organizations that are very proactive, that are concerned about bias in their data. And most of the challenges I think that I'm seeing is that lack of resources, lack of skilled resources to be able to develop an environment that is responsible, that reduces or minimizes bias or intended bias, right? You have, that's all you can do. On the other hand, from an example perspective, I think, Gary, to your point, the African American population is 13% of the US population. About 5% of the physicians are African American. So that is how disproportionate it is. So you have structural biases, you have structural discrimination, not intended to be, they are implicit, to your point. So, but more of the large organizations are waking up to that issue and are beginning to address through their data. The challenge I see is that, look, we have 4 trillion gigabytes of data that's doubling every year in healthcare. And a lot of it is unstructured data.
Yeah.
So there needs to be a recognition that what are we going to do with it? Are we prepared to handle the data? And I think that's what we're seeing, that a lot of cases they're not.
Yeah, and if we ask you the same question, when we talk about this bias, when you're seeing that, how does that show up? What are some of the examples and the ways that you see that in your work?
So one of the things that we do when we work with organizations and their data is obviously to develop models that are not biased.
Right.
So there's quite a bit of test retest. A good example, and not health related, but a good one that comes to mind is redlining of people for mortgage loans. The challenge is that as we move towards true artificial intelligence, because we're really not there, we're in a machine learning phase right now. But as we get more complicated, which we're doing now today to some extent, you don't really know how the models are developed in what we call the black box, but it's really not black box because you can reverse engineer in many cases. But you don't know whether there is bias within that environment. So one of our tasks is to ensure that as models are developed, they're retested in an environment that is very real, right? Because the other challenge we've seen is that some of the models are tested in an environment that is non-Hispanic whites, which doesn't reflect into the
Right.
other
pieces.
segments.
Oh, thank you. And so for you, Melissa, right, and I'll just let you take it from here. What are the challenges that you're seeing? And then very real examples of that would be helpful.
Yeah. I mean, I think the biggest challenge that we're seeing in the Bay Area, in most coastal cities, in cities that have areas that have gotten very expensive, is that an individual in that system can feel the pressure of that expense. They experience it. For example, in the Bay Area, low-income people who are housing cost burden are spending a third less on food and 5 times less on medical care, which means they're foregoing prescriptions, they're foregoing costs of care that they otherwise would have gotten if they weren't spending that money to maintain their rent and their housing. And for the individual, that can feel like an incredible amount of pressure that shows up as stress, and I think we've got so much research now to tell us what that means for health. But then the other thing is it can show up and feel like individual failure. Like, I keep trying and I keep working hard and I can't get to the next phase, and there must be something wrong with me. But the issue is, for places like the Bay Area right now, actually housing costs has gotten so high that it's not just San Francisco, San Jose, and Oakland that have escalating housing costs. It's actually 50% of our census tracts right now. Mm-hmm. And so people who are working really hard and decide they want to move further away to try to get out of that sense of incredible pressure and economic pressure are actually moving to places where you don't know until you get there that to get back into your job, every dollar you're saving on housing, you're spending 77 cents to get back in. Mm-hmm. And that becomes a structural issue for the Bay Area. And for those of you who do hiring, like I do hiring, you know that that becomes an issue for your hiring and for who you're looking for in the market. It becomes an issue for people who have to then commute 2 hours from different parts of the Central Valley to come back, and their kids are then at home and they're getting home tired and not able to spend the amount of time, or maybe having to put their kids right to bed as soon as they get home, and those all have huge impacts for health. And so one of the things that I think we haven't done until people started to realize that actually their kids were going off to college, coming back, and couldn't afford to live in the Bay Area except for in their basement, right? Mm-hmm. That we said, well, actually it's a structural issue that we need to do some real serious policy work around. Because one of the biases that got created in our system is we've been thinking, well, there's a few people with some poverty issues, or there's a few people who can't quite afford the private market. Let's do some charity to a bit of affordable housing. Let's do some pieces of affordable housing programs, and know that that's not going to be enough, and people are going to sit on wait lists for 10 years and call that our strategy for housing, knowing that that has such a huge impact on health. And so what we've been doing in the region is working with a coalition of partners who are looking for a strategy that is at scale. And so this year, many of you have probably seen, it just passed at the legislature. It comes from a coalition that had been working in the Bay Area to create a full housing solution in the Bay Area through the Association of Bay Area Governments and the Metropolitan Planning Organization, anti-rent gouging bill, so that people can at least predict and not have dramatic increases in rent that then cut down on food, childcare, and the other basic expenses of life. And so that bill, we expect signature by the governor at any point, will hold rent to 5% plus cost of living for families and make housing more predictable. And it matters because in cities like Vallejo, we've seen whole buildings purchased and people served with 60-day notices of a doubling of their rent. That city was able to very quickly restructure that and put the laws in place to make sure you couldn't have that much of a fast increase in rent. And that kind of stability is important because it's so big to health. That kind of stability that ends up with a family out on the street because we're in a really high cost housing market is the number one predictor of what's going to get us to the highest cost ER visits in the system, which are homeless folks who have living on the street, go into the system, get some care, go back onto the street, and then end up really as costly parts of the healthcare system, and just the costly part for individual humanity, condition, life, positivity when we're doing that.
Yeah. And I think you're bringing up, right, and if we look at everyone's collective conversation, there's this whole piece about it's not just the tech, it's not just the doctors, it's not just the community, this collaboration, it's the policy, it's the government, it's a whole big piece together. And we're getting questions in here about, how does digital health, help or hurt with disparities, and why are we not seeing, Black communities adopting the tech? I think, again, from our work, right, we really have, at Radical Health, we have a people plus tech approach. I believe, you cannot extract the two, especially when we're talking about biases in underrepresented communities. I'd love to chat with you all. So in the roles that you're in, again, tech straight up with Rubina. We have, Gary with med schools and doctors, and you, Melissa, on the ground. How do you see tech playing a role? What are some of the opportunities? And then, we'll start with there. What role do you see tech playing in digital health? And what are some of the opportunities there? Do you want to start?
Sure, absolutely. So something that we haven't talked about is that many physicians do not acknowledge African American minority women complaining about pain during, pregnancy.
Right.
So there's a lot of missed opportunity to prevent death. And what we haven't really talked about is that the African American women are 3 to 4 times more likely to die from hemorrhaging than their white counterparts.
Correct.
And to your point, Gary, and when we look at socioeconomic, we talk about social, determinants. Income and education don't play a role. In fact, they don't protect anyone, because if you take a woman of color and a white woman with the same education, the woman of color is 5 times more likely to die from a childbirth. So there are a lot of issues that we're really not addressing, that we're not even discussing them, which kind of goes back to the original discussion of we don't really talk about the realities of what is happening in the marketplace. From a technology perspective, it actually is very helpful, because part of the reason that we are seeing a high mortality at childbirth, for example. By the way, mortality of childbirth is not at childbirth. 50% of the most of it, actually, majority of it, is after the child is born, so within a year, which then, as we were talking about earlier, Social Security steps in, you're covered for 60 days, but you have a year that you can die from childbirth. So what technology does is that it helps those who are in rural areas and don't have access to hospitals or the desert, health areas where there are no health institutions that can help the high-risk pregnancies. So technology helps us in that sense, and we're seeing a lot of that with our clients. Help transitioning to more of technology. Now, the challenge is that when you have a young generation who's very comfortable with technology, absolutely. The challenge is when you have a rural community, low income, does not have access to technology, does not have access to connectivity, how you still have those problems.
Right.
So it is, although it is like telehealth, absolutely helping, there's still some challenges we can't ignore.
Totally.
Yeah, I think the other real value for technology is actually we have studied really well differences in life, in disparity. We've studied differences and disparities, right? And so we know the big research, but for people to change their individual practice, they need to see the data connected to them, right? And so as far as technology can share with individual providers, patient experience data around how patients experience what they say to them and how they treat them is incredibly helpful, because sometimes people don't know. Sometimes people don't know and don't care, but often they don't know that that's how they're being received. And so if they don't know that that's how they're being received, it's helpful. And if the institution can see that actually there's been conversations with a provider and they know how they're being received, and that hasn't mattered to the change in their practice, then you can have a very concrete conversation about whether or not they're the right person to be there serving those clients. And so I think technology is the piece that takes what we know as a meta issue and brings it down to the individual practice and change behaviors, which is the hardest part of anything, I think, in changing a system. The other thing is, for the state of California, for those of you who are here, and I think increasingly for other states in the country, there's an incredible level of energy around screening people for the social determinants of health. So making sure they have stable housing so that they're healthy, making sure that they have enough food, money, to be healthy. There's an initiative running across all of many health centers in the state of California and across the nation, starting that screening process. There's an additional layer in California that's been very interested in medical screening at the pediatric level for trauma in ACEs. So this is the idea that there are adverse child experiences based on a study from Kaiser many years ago that many of you know, I'm sure, that showed that the early experiences, negative experiences that people had, and this was in a population not so much of color and actually fairly affluent in the scheme of things, that much later chronic diseases showed up for those people because of things in a highly correlated way to the kinds of negative experiences they had as young people. And so there's been all this work to start screening for traumas. The issue is that if you screen for traumas and you screen for things that people need and share with them that actually to be healthier, they should be in housing that's cheaper so they could be spending more on this, or they should be doing things that are outside of their control in the current system, they end up in a place of increased stress rather than increased health. And so if there are ways, and I know there's a couple of people I'm talking to after this session, that some of your organizations are thinking about how you make the link from what the doctor is screening to the social needs that people have, and to the places where they can get to those needs, that's an incredible helpful set of technologies, and it's probably a set of technologies in human interventions. But that could be really helpful.
And if I may add something, and it is a combination of human and machine.
Yeah.
Yeah, and to your earlier point, it's not all about technology. And we totally rely on the fact that it is a combination of human and machine and technology.
Right.
Yeah. I'll pick on it. I would simply say that clearly technology can help to make a system that would benefit from efficiencies better.
Right.
Standardizing care can only go so far, right? I think in the goal, just like precision medicine aims to sharpen the focus of interventions at the level of the individual, technology needs to be flexible in that same way. We can only get there if we include perspectives from diverse individuals and people at the front end,
Right.
and identifying the problem, and perhaps even participating, creating the tech-driven solution, and engaging effectively with poor communities and communities of color. We're in a position, I mean, it's interesting, when I scanned the states, including the West Coast, to ask the question, who was connecting the dots between diversity and inclusion and innovation opportunity?
Right.
No one in the healthcare system. This would, believe it or not, would be a first where a large healthcare system is aiming to do that. Right? To do that well means changing the dynamic between a large system and a community. Right? And so that the problems that we aim to address, the way in which we educate, train, and particularly include women and minority students, trainees, et cetera, in the mix will be based on what's coming out of our community through community partners like Ivelyse, who's a partner in this work, community partners like Rubicon MD, like 100 Black Men, et cetera.
Right.
So this is a critical moment in time. And back to the question of race, when I think about race, I think about all the ugly stuff that's been upon us historically, but also opportunity.
Yeah.
Right? In this room, we represent the opportunity to change that and accelerate the rate in which we change the way in which we engage technology in a more precise way with people of color, women, and communities. And I think unless we are prepared to do that, then I think that we will miss perhaps the grant opportunity in front of us.
And I love that you went right into that, because I think, right, we know, I mean, we can Google the problems. They're kind of the best thing about all you journalists that are covering this, thank you, because now we're seeing it, kind of in the forefront. We know that there is a huge problem in the United States as it relates to health. We are wasting money. People are dying, but we have a room full of people here and on the internet that we can kind of tell them what we need to do and what we need next. So my question, in our last few minutes, is what can the folks in this room who are creating technologies, investing in new solutions, running healthcare systems, and kind of leading this next charge, what can they do to support you, your cause, and to really look at overcoming this bias in health? We'll let it, that was a big charge, so whoever wants to start. Do you want to start on this side, or?
Sure. Happy to. One, we know a lot about the problems in terms of the disparities that we have, and we know the social good that could come from really addressing differences in life expectancy and differences in experience in terms of people's health. And so because we know that, it's really helpful to have technologies that are not trying to figure out what we already know, but are trying to help find individually where we can have changes that are supported by institutions. And so particularly patient experience information that is very concrete and can then be translated into the institutions to support their changes in how they interact with clients is really, really helpful. And it's increasingly helpful to have data that can help understand when actually we've got changes that we need in a system that are more about accountability, and to have a really clear data that we can point to around accountability around individual providers or systems. The other thing that is incredibly helpful is to start to make the connection between the social determinants of health, which the World Health Organization, the California Department of Public Health, and the Office of Health Equity have all said are the primary contributors to health, to start to make that connection and into the policy arena in the ways that we can really address those issues, either through matching people to the services and opportunities they need. And when I say services, I don't mean in the traditional way we've always talked about social services. I mean the kinds of opportunities that help people move out of poverty, and then the kinds of policy measures that help people that make sure we have jobs that help people move out of poverty. And so I think those are things that, that technology can be really, really assist in.
I think the first step is we need to define the problem. I question if we have the problem defined or we're generalizing to the point that we know what we're solving. I sometimes question that. And to Gary's earlier point, I think it is really an individual or granular level we need to begin to look at rather than stereotyping and generalizing it. That's a very important issue to address. But we need to address this area, racial justice, with a critical lens on. And we can't just talk about it at a high level. And I think we tend to do that. We've, to some extent, done that today as well, because once you begin to drill down, it really takes many hours to discuss it.
Right.
From a technology perspective, I think there's a tremendous amount of data that's not being used effectively. And as I said earlier, part of it is lack of resources, lack of skills. But the other part is that most of that data is in electronic health. It's unstructured data, and a lot of organizations don't know what to do. So understanding what your data says and studying it at a granular level is very important.
Great, thank you.
I would simply say, I think it's past time to connect the dots between the promise of innovation, including technology, with real grounded, granular community needs. And a way to do that is by investing in a pipeline that is particular to women and ethnic minorities, and that's really the work that we're trying to do. We will put this in place. We'll launch in a couple of weeks. That's number one. And so that the potential available to you all is much more diverse than what it's been historically. And then figuring out ways to better engage the communities around us, particularly the communities of color. Back to your point, Rubina, we have functioned as a system from top down for far too long.
Yeah.
Right, and how do we know that we're addressing real, daily, day-to-day problems for which the solutions will make the difference? So we're in a position to do better than that. We hope to be an example of that. And I simply say to you all, if not you, then who? If not now, then when?
And when? Yeah, this is great. And I think that's it. So I'll say we need representation, invest your money in Black and brown and underrepresented founders. Make sure your C-suite, your board represents the communities you want to serve. And this is a great, great panel. And thank you all for your time. And thank you, everyone, for being here. Thank you.
Thank you.